This is another discussion on traumatic brain injury with a special emphasis on the axonal injury syndromes. The mechanisms by which the brain gets injured include impact. Skull fractures occur, which might involve the convexity or the skull base. Convexity fractures may be simple or they may be depressed. Skull base fractures may result in cerebrospinal fluid leaks. They often produce cranial nerve injuries, including optic nerve, olfactory, and the other cranial nerves. And they might result in vascular injuries. Inertial injuries are because of the acceleration-deceleration forces. Axons and tracts rupture. Microvasculature ruptures and cranial nerves may be involved by inertia. Penetrating injuries occur because of sharp objects penetrating the skull. They can also occur because of projectiles or bullets traversing or entering the cranial cavity. Coming to the pathophysiology of axonal injuries in the traumatic brain injury complex, the conventionally described sites of rupture are the sites where inertial stress is maximal. This includes the gray-white junction, the corpus callosum, or rather the area just adjacent to the corpus callosum, and the brainstem. The grades of injury or grades of severity of axonal injury range from the relatively inconsequential axonal stretch without anatomical disruption, which contributes to the so-called concussion syndrome of Yore. Axonal microskeletal ruptures may occur, which produce the histopathological feature of axonal varicosities, and complete axonal ruptures may be present, resulting in axonal retraction bulbs. Radiological markers of inertial injury include dot hemorrhages, which are not because of axonal ruptures alone, but because of the rupture of the microvasculature associated with axons. Intracerebral hematomas may also occur if the bleeding is significant. The clinical profile of axonal injury syndromes ranges from concussion syndromes. Concussion syndromes may involve consciousness, and the loss of consciousness which accompanies a traumatic brain injury is usually due to the stretch of brainstem fiber bundles. Amnesia syndromes are again because of axonal stretch. The bundles which extend from the cortex to the hippocampus and back may be stretched, resulting in a temporary failure of conduction. Vomits occur because of multiple reasons. Cerebrospinal fluid being driven back may impact upon the chemoreceptor trigger zone or the vomiting center of the fourth ventricular flow. Bundles of fibers may stretch, resulting in a stimulation of the vomiting center. And then, of course, increased intracranial pressure may result in triggering of the vomiting reflex. Major axonal injuries result in many coma syndromes. You have minimally conscious states. You can have a patient who is vegetative, a person who breathes, who is fed through a rice tube but has digestion, and whose organs are functional but who is not responsive. Then you have conscious, unresponsive patients whose brain stems have become active, They might have roving eye movements. However, they do not respond meaningfully to stimuli. Further up the scale, you have conscious, responsive patients who yet lack cognition. And then, as they recover, you have conscious, cognitive individuals where cognitive processing loops from the cortex to the forebrain and back reverberate. How do we manage axonal injuries? There is not much we can do about an axonal rupture. Anti-edema measures in diffuse axonal injuries have a limited role because axonal ruptures themselves may not produce much brain edema. Mannitol has benefits which go beyond reduction of intracranial pressure, like improving the microcirculatory flow. Anti-seizure medications have a role. Immediate seizures are not because of axonal injuries. Usually it is because of an excitotoxic surge resulting in hyperactivation of neurons. Early seizures involve both hyperactive neurons and a failure of lateral inhibition. The inhibitory interneurons become dysfunctional. Axonal injuries may result often in delayed seizure syndromes, and they also produce post-traumatic epilepsy as neosynaptogenesis compensates for ruptured axons. You can have abnormal circuits which form, which may result in epileptic circuits. Anti-inflammatory drugs have a role. However, major trials on steroid use were actually counterproductive and abandoned because of poor outcomes. Oxygenation has a role in recovery. Recovery involves restoration of conduction through intact axons. Axons which are ruptured may reconnect through other routes by neosynaptogenesis. Neuronal plasticity may assist in functional recovery when connected axonal neuron complexes take over the function of dedifferentiated neuronal islets. Stem cells have a limited role. They migrate from the periventricular zones to areas of injury. However, the integration and functional restoration role is limited. Delayed recoveries, often dramatic, have been anecdotally recorded, where people wake up suddenly after months or even years. This is attributed to reconnection of intact neuronal islands by neosynaptogenesis. To summarize, the traumatic brain injury load in any head injury syndrome includes both impact and inertia. Almost all head injuries have axonal injuries. The classical radiological markers like dot hemorrhages may not reflect the quantum of axonal injury. Traumatic brain injury may not be radiologically evident if the injury is mainly because of axonal ruptures or axonal stretch. Axonal injuries affect both consciousness, that is through the brainstem, and cognition, which involves connection between the neocortex and the core brain. There are only limited therapeutic options in the management of axonal injury syndromes. Delayed recoveries occur because of axonal reconnections. Sometimes these recoveries can be gratified because neuronal islands which store information and education may be intact and reconnections result in restoration of function.